At ASCO this year, our group has led an analysis, a meta-analysis of randomized trials containing Daratumumab in respect to its effect on high-risk population. The first author is my colleague, Dr. Smith-Geary. And we have seen, of course, Daratumumab be very impactful in terms of progression-free survival in both relapsed or refractory myeloma and also newly diagnosed multiple myeloma. One early concern, however, particularly in the newly diagnosed setting, is when you look at subset analysis, the patients with cytogenetically defined high-risk disease, those are the patients with 17p, translocation 414 or translocation 1416, did not have a significant benefit in terms of progression-free survival in any of the newly diagnosed trials, those being Cassiopeia, Maya, and the Alcyon. So the reason for that is a little bit tricky. This could be, because Daratumumab does not have a meaningful impact in high-risk patients, but also could be because the relatively low proportion of patients with 17 with high-risk cytogenetics that are included in those trials, potentially diluting out some of this benefit. So when you have, in order to address the problem, we meta-analyze all the randomized trials that reported PFS in both newly diagnosed setting and the relapse refractory setting, and they had a comparison between standard regimen versus that regimen plus Daratumumab. And what we're able to see is that first and foremost, there was not statistical heterogeneity across those trials. So even though we're putting trials together that have a different eligibility or different population, for example, Maya, Alcyon, and Cassiopeia, statistically there's not a huge difference on how Daratumumab did affect the outcomes. And I think the good news for the patients is we're able to show a statistically significant improvement in PFS for high-risk multiple myeloma patients, both in the newly diagnosed setting as well as in the relapsed and refractory setting. That hazard ratio was about 0.65, so it's quite a substantial impact, which tells us the problem all along was probably not that Daratumumab did not work in high-risk patients, was that there were too few of those patients in each of those trials to make that difference statistically significant. So that, I think, make us all feel more reassured that Daratumumab-containing regimens are appropriate for patients with high-risk chromosome abnormalities. What that does not tell us is whether Daratumumab-containing regimens are better than other combinations with novel agents, a question that can only be answered with clinical trials.